Hi, Dr. Rossi.
Hi, Gabby. Hi, how are you?
Hi, I'm good. How are you?
Okay, good. Okay, what's
Awesome.
the
Well,
topic today?
well, good evening, everyone. The topic for today is C-section Isthmocele in IVF. So our topic for our live last night was uterine fibroids. And then we also discussed adenomyosis. So the live for tonight, as mentioned, C-section scar, Isthmocele. Dr. Rusty will kindly provide an introduction now on the topic before we dive into the questions.
Yes, so today we'll be discussing Isthmocele. So Isthmocele, which is there's another name for that, is a cesarean section defect. So it can happen after cesarean section in some patients. So in Isthmocele, after cesarean section, the scar doesn't get closed fully. So partially it gets closed, and you have some defect left on the scar. So the later you have a fluid collection inside that defect. So it's like you have a small pouch of a cavity in the middle of cesarean section scar. Then you have a fluid collection inside that pouch. So when you actually do scan, you can actually see as a small fluid collection area in on the cervix, in front of the cervix, just behind the bladder. So in patients with a cesarean section, it indicates there is a defect and there's a collection of fluid inside that scar.
Thank you so much, Dr. Rusty. And can Isthmocele cause infertility?
Yes, so generally most patients with Isthmocele don't have any problem because that Isthmocele fluid is not communicating with cervix or uterus. So in some patients where this fluid, so where Isthmocele, which is pouch, drains inside the cervix or uterus, it can cause problem. So if it drains, so then it can cause bleeding. Usually when menstrual period happens, menstrual blood can come from, let us say, from the inside uterus cavity, drains into the cervix, and goes into that pouch of cesarean section scar and gets collected there. So after menstrual period, then patients can have a small discharge of blood, menstrual blood, after the period. You have like strictly trickling of blood after menstrual period. So that can interfere with the frequency of having intercourse. That can be one of the causes of infertility. And also, if this draining fluid communicates with the uterine cavity, it can flush back into the cavity. That can reduce the chance of implantation. So it really depends on whether first this Isthmocele fluid is communicating with the cervical canal. Second, whether there's a communication between cervical canal and Isthmocele and the uterine cavity. If it's flashing back, yes, it can reduce the chance of implantation. It can cause infertility.
Thank
And
you so
also,
much.
so one more thing, also Isthmocele can cause ectopic pregnancy. So especially if the fluid is communicating, that can irritate the uterus, and uterus can erratically contract. So the embryos can get pushed up to the fallopian tube. It can cause tubal pregnancy, or even embryo can implant inside the pouch of Isthmocele, inside the cesarean section scar, which is ectopic pregnancy, which can cause bleeding and problems. So it's rare. The Isthmocele or cesarean section scar ectopic pregnancy is very rare, but it can happen.
Thank you so much, Dr. Assi. So there you've just mentioned that a problem caused by Isthmocele is ectopic pregnancy. Would you say that is the main problem caused by Isthmocele, or are there other problems that are derived from Isthmocele?
So the mainly from infertility point of view, it reduces implantation. This is the main problem of Isthmocele because of fluid collection inside the uterine cavity where the embryo should implant. It reduces the chance of implantation. Let us say if couples trying to conceive naturally, so after embryo gets fertilized in fallopian tubes, then after 5 days when it is blastocyst, it comes to the uterus. So the uterus or endometrial lining should be optimal. You shouldn't have any fluid inside the uterine lining. So if you have a Isthmocele fluid flushing back into the cavity, that fluid is toxic for the embryo because it is leftover menstrual blood, and also that's the inflammatory exudate fluid. So there's a lot of chemicals which is toxic for the embryo. So embryo cannot physically implant if there's a fluid. It just starts floating in the fluid. So, or that fluid can be toxic. So it can reduce the chance of implantation. Yes, women can get successful pregnancy with Isthmocele naturally or with IVF, but chance of implantation is reduced. So main problem Isthmocele causes to fertility in IVF is reduction in implantation.
Thank you, Dr. Asti. And how do you diagnose Isthmocele?
So Isthmocele, first you diagnose clinically, so with symptoms. So if patients had a cesarean section and if their menstrual period changed, if they start bleeding between the menstrual periods, so which is called intermenstrual bleeding. So, or if they have a trickling of blood after stopping menstrual period, then you suspect they may have Isthmocele. So, and also it can cause bleeding after intercourse as well. So, and you suspect. So the diagnosis you can make using ultrasound scan or HICOSI or MRI. Usually ultrasound is sufficient. So when you do transvaginal ultrasound scan, so you can actually see on the on front wall of the cervix or back wall of the bladder between the cervix and bladder, you have got a dark area, so which is filled with the fluid. So you can diagnose with ultrasound scan. So sometimes it's essentially you need, when you diagnose, when you measure that Isthmocele, first you need to measure the size of the Isthmocele and measure how much fluid is there, and also it's helpful to measure the thickness of the Isthmocele. So because thickness is more important for pregnancy. Let us say, hopefully you do IVF and get successful pregnancy, but you want to know the thickness of the defect between endometrial cavity to the Isthmocele. So because if you have a huge defect, this very thin distance between cavity to Isthmocele, then there's a higher risk of problems in late pregnancy. Certainly, it's recommended to do cesarean section because of very small risk of defect opening up during delivery. So yeah, so if you're not quite sure, you can do HICOSI. In some Isthmocele, it can be elusive because if it's draining Isthmocele, fluid can come in and out. So in some scans you can see, and other scans you may not be able to see. So if this is the case, you can do MRI and check the thickness of the defect, or you can do HICOSI where you push the fluid through the cervix, and if there is Isthmocele, you can see the fluid going into the false tract of Isthmocele and also the cavity. So yes, ultrasound scan is sufficient. Also, you can do MRI or HICOSI to diagnose.
Thank you so much, Dr. Asti. And in fertility management for Isthmocele, how do you manage it and treat it?
Okay, so generally, so if there is Isthmocele, usually we manage it in IVF setting. So unless patients are doing ovulation induction or IUI, you cannot tell when this fluid is coming in and out inside the cavity. So, and also it's not generally recommended to do ovulation induction or IUI if there is Isthmocele because chance of successful pregnancy is very low. Normally you do IVF. So in IVF, really it depends on, again, the same thing, whether the Isthmocele is communicating. Sometimes like fluid can get interrupted, it's not communicating, it doesn't cause any problem. So you don't need to worry about it. If it is communicating with the cervix and uterine cavity, then you may need to manage. So first, whether it is communicating with uterine cavity, which means whether fluid is coming and flushing back into the cavity. So first, and second, whether there is a fluid inside the uterine cavity when you want to do a transfer. So generally, if you detect Isthmocele when we are doing IVF, if there is a fluid in the cavity of the uterus, we cancel the transfer. You get the eggs, create the embryos, freeze the embryos, and cancel the transfer. So then Isthmocele may cause problem during fresh cycles more than frozen cycles. Why? Because in fresh cycles, when you stimulate your ovaries, you push a lot of blood flow to your ovaries and your uterus because your estrogen is so high. So that can increase production of Isthmocele fluid. So, and in natural cycle, you may have a lesser amount of fluid, and you may not have a fluid inside the uterine cavity. So, one approach is if you see in fresh cycle, you freeze the embryos, and next time you can do natural frozen transfer cycle where you have physiological amount of estrogen, and hopefully you do not have a fluid inside the uterine cavity, and then you can transfer. If you again see fluid in the uterine cavity, then you need to either deal with the Isthmocele surgically, or you can try HRT frozen cycle. In HRT frozen cycle, which is the artificial frozen cycle, you have a lowest amount of natural estrogen, then hopefully you do not have a fluid. If you keep having fluid inside the uterine cavity at the time of transfer, then you need to deal with Isthmocele surgically. Also, another option is if you see some fluid initially in the cycle, then if you really want to transfer, then you can do scan on the day of embryo transfer. If there's no fluid, then you can transfer. But still, you should expect your chance of implantation is a little bit reduced because there was a fluid in that cycle, in that endometrium. So ideally, you should cancel and then treat the Isthmocele, then do the transfer.
Thank you so much, Dr. Asti. That does conclude all the questions that I had for you for this particular topic. So before we round out the live, was there anything else you wanted to share?
Yes, so I'd like to explain the treatment of Isthmocele, how you treat. Let us say you keep having fluid inside the uterine cavity and you cannot do embryo transfer, you keep canceling embryo transfers. Then you need to treat the Isthmocele to improve the chance of implantation. For that, there are two ways of treating Isthmocele. One is hysteroscopically, which means they put cameras through the cervix, go into the uterus, then treat it with a hysteroscope. So, and second approach is with a laparoscopy, with a keyhole surgery. And hysteroscopic resection is not very effective. You can do very limited procedure with hysteroscope. So essentially you would do that just, let us say you have got cesarean section niche, and you have some scar tissue. With a camera you can go and just open up that scar and drain the fluid, and you can just remove some edges to make it edges more raw so that hopefully it closes, and you don't have a collection of fluid, but it's not very effective. So second approach is a laparoscopic resection of the Isthmocele, removal of Isthmocele and a repair of the Isthmocele. For that, you need to have a laparoscopy procedure. Then you open up the old cesarean section scar, you remove the edges, and resuture the cesarean section scar. Because in that what happens is when you have a raw edges, new edges, then when you approximate the edges properly in suture, it's very likely that it will heal fully and you don't have any defect. Then you wait maybe 3 to 6 months. You need to give it time for it to heal before you do embryo transfer. Give a little time, then do scan. Before you do transfer, check to make sure Isthmocele has not recurred, then you can do the transfer. So that then you should have a very good chance of successful implantation.
Thank you so much, Dr. Asti, for explaining the treatment of Isthmocele. That does conclude our live for this topic. So thank you to those that joined. And as always, the screen recording of this live will be uploaded to Dr. Asti's TikTok and Instagram. So the live that we have planned for tomorrow evening will cover endometrial polyps. So please stay tuned for that one. So thank you so much again, Dr. Asti, for your amazing expertise in this area.
Thank you. Thanks, Gabby, for organizing. Thanks for everyone for joining. So we will be posting whole video on Instagram and TikTok and YouTube, and we will be posting the questions separately also on these socials.
Yes.
Have a
Thanks
nice
so much,
day.
Dr.
Thank you.
Asti.
Thank you. Thanks.
Bye,
Thank you.
everyone.
Thank you.